found often all three in the same patient. It started for me with a lady who, aged 33, came in 2005, first person I ever thrombolyzed, and she ended up at post-mortem to have systemic lupus erythematosus causing Liebman-Sachs endocarditis, which embolized to her brain. To use the word stroke for this pathology risks trivializing the discussion. It at least impoverishes the discussion. And other examples include this 68-year-old lady who came in with multiple intracerebral hemorrhages, but these were hemorrhages into areas of infarction related to her non-bacterial thrombotic endocarditis related to her lung cancer. We've had the 28-year-old male who died of a basilar tip occlusion, and the only problem we found was his occluded basilar artery, which was the only pathology in the rest of his body. His carotids were pristine, but he did have one area of atheroma in the parent subclavian artery with lines of Zahn, they're called, successive episodes of thrombosis, and that was the only thing we found. We still don't know why a 28-year-old should have such focal subclavian disease. And to emphasize the complexity, and in keeping with Mel's comment, this gentleman had a large thalamic hypodensity, and he was listed for the neuro-oncology MDT until a clever neuroradiologist said that is a venous sinus thrombosis involving the straight sinus and the internal cerebral veins, cured by anticoagulation. So to try and use the word stroke to in some way describe those patients, I think, is to impoverish their situation and to impoverish the discussion. It can go on to hemorrhage. All of these patients have been randomized in ENRICH AF. And just a note for trials, some of our colleagues to my left have recently been in a New England Journal of paper, courtesy of taking part in big, useful trials. This lady's in ENRICH AF. She has a lobar intracerebral hemorrhage. She has cerebral amyloid angiopathy. She's randomized in ENRICH to avoid anticoagulation for her atrial fibrillation. That's the degree of detail I'm suggesting we need, rather than saying she's had a stroke. This lady had a convexity subarachnoid hemorrhage, atrial fibrillation, randomized in ENRICH AF to take anticoagulation for her risk of emboli from her heart to her brain. This patient's got a thalamic deep intracerebral hemorrhage, randomized in ENRICH to edoxaban, and this person had a primary intraventricular hemorrhage. All of these patients will say they've had a stroke, and yet somehow it doesn't do justice to the profound nature of their pathology and the problems they face. We also see rarities. This young boy, aged 18, it only took us 18 months to make the diagnosis, but he had DADA2 deficiency, a totally curable condition, monogenic cause of vascular disease affecting mainly the pons and midbrain. And just to finish, we're very keen on thrombolysis. It's produced a stepwise change in the way that patients with stroke are managed. I've used the word. This man had a left frontal lobe infarct. He was thrombolyzed within 3 hours. He bled into his infarct. So it's an infarct, then it's a hemorrhage. 7% of people within the first 7 days will have some sort of hemorrhage after TPA. So all of this has to be considered, the anatomy, the pathology and the pathophysiology in the real world clinical context, and one of the big issues is whether they are frail or robust. And one way of thinking about frailty is the dandelion model, not to trivialize it, but just to convey the sentiment of it. And it's readily apparent to all of us in practice that if you are robust, you carry your disability. If you are frail, that same deficit has a dramatic effect on you. So I've made the case, even with Martin sitting there having spent 4 years putting together the guidelines. Thank you, Martin, for fantastic work. I am going to suggest that somehow, perhaps just between us as colleagues, we avoid the word stroke. And yet, when it comes to the clerical and the political, it has such emotional valency, perhaps we should stick with it. Thank you.